We'll get started. I want to let you guys know that we will be recording this. It will be uploaded to AAEM EMSS website in about 48 hours. So welcome to the American Academy of Emergency Medicine Emergency Medical Services webinar titled Emergency Triage, Treatment, and Transportation, also known as ET3, and Community Paramedicine. I'm Dr. Scott Goldstein, and I'll be moderating tonight's session. So I'm going to stop sharing my screen. If you're in the audience, we did this over Zoom to make this as interactive as possible. So feel free to ask questions in the chat. I'll keep track of them, and I'll ask Chris later. If you want to raise your hand, you could ask questions in the middle of this. We'll make this as interactive as possible. So don't be afraid to raise your hand or put questions in the chat. And we do encourage all participation, to make this as interactive as possible and enjoyable.
Dr. Goldstein, could you go on camera? Please go on camera.
Oh, I'm sorry. Is that better? There we go. Sorry about that. So I'm Dr. Scott Goldstein. I'll be your moderator. This is what my face looks like. So let me introduce our speaker tonight. Is Christopher Maddock. He has a bachelor's. He's a nationally registered paramedic and community paramedicine instructor at the University of Pittsburgh School of Health and Rehabilitation Sciences, Department of Community Health Services and Rehab. He's here to talk about emergency triage, treatment and transportation, and community paramedicine. The discussion demise of emergency triage, how it could be revived and how community paramedicine could fit into the current EMS model. Paramedic Maddock has been in emergency services for over 36 years as a paramedic, a firefighter, a leader, an educator. He started in New York, where all great things start. It's because that's also where I'm from. But anyway, he started in Harlem and worked in New York City for over 16 years before moving to Chicago's fire department and then later to Minnesota. Throughout his career, regardless of rank, he's been involved in service and education development and delivery at all levels of public safety. He taught in several areas of in public safety, from municipal, hospital, and government, up to federal at the Department of Natural Resources. When he was in Minnesota, he was in the inaugural class of the community paramedicine and has been involved in community paramedicine since at the local and state level. He has become the director of the Northfield Hospital EMS Community Paramedicine Program in 2015 and is looking forward to fostering the next stage of evolution in EMS via mobile integrated healthcare and community paramedicine. It's a mouthful. So let me once again welcome Chris to Emergency Triage, Treatment, and Transportation and Community Paramedicine. Paramedic Maddock, this screen is yours.
Good evening, and thank you, Dr. Goldstein. Appreciate you inviting me, and thanks to everybody who's joining us online. And I hope that this discussion will be fruitful and foster some good ideas and help move the needle a little bit further along. All right. So, Dr. Goldstein, where would you like to begin?
So, what have you kind of let's start with, if the groups have any questions, please start putting them in now so we could kind of, get a cadre of them. But, can you discuss billing and reimbursement in the community paramedicine MIH model?
Certainly. As we may all, or maybe we're not aware, I'm not sure, reimbursement in emergency medical services is a pay for play. You show up, you call, we haul kind of thing, where you really only get paid if you transport a patient to a receiving location, facility, whatever. And as we well know, there's a big chunk of EMS calls that do not result in transports and therefore do not result in reimbursement. So we don't get paid for those. Community paramedicine, mobile integrated healthcare as a group is reimbursed under a number of different models in the United States, primarily under grants, which is a terrific way to get things started, but it is not a sustainable model. EMS started on grants, and it was great until President Reagan said, nope, we're done, and cut the funding. So a lot of MIH programs have grants that are either in the process of running out or will run out fairly soon. Other systems will support an MIH program through a set aside or earmarked portion of the budget where the department is paying for the provision of community paramedicine service without regard to reimbursement. They're funding it to allow cost savings in other areas. And but again, that's kind of limited and does not apply generally to a 911 service. And then there are hospital-based systems and other entities that are funded with direct contracts to third-party payers and health insurance providers to manage specific patients. There are some accountable care organizations that have adopted community paramedicine as part of their service model to address patients who would otherwise end up being very high utilizers of service. And for those of us in the field, we generally refer to those patients as frequent flyers.
Okay. Thank you. Does anyone have any comments, questions about that?
So just to follow up on that, one of the things that I'm hoping part of this discussion will generate, part of the legislative process will address, maybe hopefully, fingers are crossed, is to redefine how EMS gets reimbursed. The ET3 model was a big part of that. Originally, it was to provide reimbursement payment to services for transporting other than to a hospital or to treat the patient in home. And it is something that the Center for Medicaid and Medicare Service and the federal government have to try to address in order to keep EMS services in operation, because the lack of funding is currently resulting in a number of EMS service closures. We just lost another EMS service here in Pennsylvania because they couldn't afford to stay in business anymore.
So along those lines, and along the lines of one of the questions that we have is, what role do you think telemedicine has to play in community paramedicine? And along those lines, Adonis Wings was asking, how do you see the telemedicine, and how do you see advanced paramedic practitioners in community paramedicine?
Oh, telemedicine is it's already being utilized in community paramedic programs, but it has a role much wider than that. My personal hope for community paramedicine is to integrate in the space between 911 provision and regular scheduled established healthcare provision, meaning we know that patients who are calling for help may not have a very high acuity problem. And I'm sure there's a number of eye rolls in the audience right now, or a bit of a, oh yeah, been there kind of thing. But what we end up with is patients who are being taken to emergency rooms, and they really don't need to be. They need help, they need care, but not at an ER level. And the introduction or use of telemedicine by 911 providers, where they can help establish an assessment at the level of the physician, wherein they can say, you know what, you're right. Based on the vital signs and the assessment, you don't need an ER, but we're going to send out a community paramedic. That telemedicine component is now a part of that response as well. And that means the physician can be involved with the CP directly or with the patient or both. You can also include the primary care providers in the consultation for what needs to happen with the patient. And it gives that real-time interaction and decision-making process. So telemedicine is used now, should be used in the future. I think will be greatly expanded in the future. And honestly, with the technology improving the way it is, I think that it's going to make a lot of things that we've taken for granted much, much better. So it's got some really good use now, and I think better potential in the future. In addition to that, and back to the billing component, if telemedicine is used with a physician on the other end, that's billable. That is billable as a clinic visit. So whether it's an EMT crew, a paramedic crew, or a community paramedic, or another type of practitioner, when the physician is involved in the telemedicine component, we can all get reimbursed for it.
And what's your thoughts on the advanced practitioner with community paramedicine? Do you feel that it's necessary? Do you feel that there's a certain level of expertise that's needed?
So first, community paramedics, because of the responsibilities that they have, should be well experienced providers. In some states, for instance, Minnesota, in statute, you have to have a minimum of 2 years 911 experience before you can go to paramedic or community paramedic school and get your education there. Because of the nature of the 911 calls being that you may have a situation that there's some occult issue going on, and it's going to take a practiced eye to find that during an assessment. CPs should be in the level of an advanced practitioner. Right now, it depends on the state. A lot of the training is around 10 or 12 credits worth, and perhaps 100, 200 hours of clinical training above the level of paramedic. And what that gives you is a greater understanding of key components like the structural drivers of health, advanced physical assessments, more detailed neurological assessments, things along those lines. And it is necessary because you're now in a patient environment where you have to be more thorough. You have to do a lot more. There's a much greater level of patient interview that has to take place because we are taking a lot of the components that would otherwise happen at a clinic or in a clinical setting where you have a physician or a nurse and that all of that setting. We're taking that into the home. And this has been done very successfully, I might add. Until recently, we had a program here in the Pittsburgh area, Urgent Care at Home, where community paramedics, advanced practitioners were going into patients' homes under urgent care requests and providing physical assessments and treatments and getting reimbursed for it. So that it is important to have that extra training and that experience going into it.
That makes sense. Anyone have any questions? There's some topics that have been brought up, talking about mental health importance with community paramedicine and kind of trying to merge those together, especially in key demographic areas. So along the lines of, people that are in the need of this the most is usually the people that can't pay for it. In the current EMS model for delivery of pre-hospital care, do you think this is sustainable in the U.S.? Why or why not?
Certainly. The answer is no, it isn't, as we've already found out with closures of EMS services. The current model, pay for play, the transportation reimbursement model, doesn't work. This is primarily because EMS originally was incepted into a public service We were put onto the roads and the highways to help deal with the trauma and the traffic accidents and things along those lines, which is that's public safety. That's not healthcare. And we spent a lot of time in the public safety space, but we have transitioned with the addition of skills, with the addition of knowledge, with the shrinkage of cardiac equipment and ultrasound and IVs and all of these things that are now portable. And we have moved them into the public safety space with the expectation that we are now providing health care. And EMS in general is in that weird intersection in public health, public safety, and healthcare. But unfortunately, the model for reimbursement has moved away from the grants or from public funding and is now almost exclusively in the realm of healthcare reimbursement, which puts a lot of very difficult pressures on EMS. As such, the need to keep people employed, to provide fuel and maintenance and all of the other elements that are required to keep an EMS service going, they're not being paid for, and services are losing money. This results in some equipment not working quite as well, being forced into overtime, having very high call volumes, and general job dissatisfaction. And that's just one of multiple factors that are causing EMS services to decline and to not be able to attract new employees and to provide care and service as the 911 call volume continues to increase every year, year after year. So what we're doing now, we know isn't working, and it will not be sustainable for the future. We need to have an alternative. The ET3 model was probably one of the best concepts for change that we've seen in EMS in a very long time. Unfortunately, the federal government got a hold of it, and not dissimilar to HIPAA, which was a good idea before the Congress got into it. But with the federal government saying, okay, we're going to do this, they put a number of parameters in front of the ET3 model. And as a result, we lost the ability of the majority of services in the US to participate. As such, the 240 some odd services that actually participated out of the over 24,000, that wasn't enough to sustain any usable data. And so they shut the program down. Well, I mean, kind of what do you expect? So what we need to do with EMS is we need to update, upgrade our status. We need to be an emergency service. If we can't get that, we need to at least be an essential service. Right now, there's only 13 states in the union that recognize the provision of emergency medical services as essential. There are no states that have it as an emergency service. So without that level of parity, we're not going to be sustainable. With what we have in terms of reimbursement, we don't get enough money to keep an ambulance rolling. If as a chief, I send a crew out on a call, I'm paying for their salary, I'm paying for the fuel, I'm paying for the maintenance, I'm paying for the base, I'm paying the insurance, I'm paying for all of this stuff. And if we get there and the patient just needs some assistance, getting up or something like that, I can't get paid for that. And so that's lost money. And now I've got somebody who's really tired of this kind of call and they call in sick. Well, now I've got overtime. There are a lot of factors that play into this. Establishing EMS as an emergency service, I think is a big step in that direction. Revitalizing ET3 with the right provisions, allow more services to participate. The requirement, one of the requirements to get into the ET3 program is you had to have 15,000 calls a year. Well, the majority of services across the country don't have that. The vast majority, somewhere in the neighborhood of, I think, of 16 or 17,000, don't even come close to that. So that has to be expanded. And then the CMS RFP model said in bold letters, no EMTs or paramedics may be that um, healthcare provider that is part of the treatment at home process. And okay, I'll give them that. We don't have a national provider identifier. We are not necessarily involved at that level, but we really should be. And with the addition of community paramedicine and telemedicine coming together to become that physician involved clinic visit, that would be a boon to the process, and it it would, I think, revitalize a lot of the components that are required in order for EMS to be here in the next 50 years. So look, we had a question about the failure of ET3. Okay, so it looks like, I guess we covered that one. So I hope that in a roundabout way answers why we need to change things.
Yeah, so along those lines, like, what are your thoughts about the CCT model as it relates to utilization, viability, and the operational cost versus benefit for especially rural areas and metro venues?
So a CCT model by meaning the critical care.
Yes, critical care transport. Sorry.
Okay, yeah. So that critical care transports are they're good, they're necessary, but they would be very limited in their volume. As we've already discussed, the requirements of most patients are not very acute. They uh, unless and we all know that a life threat or a life-threatening call or situation is 5%, if that, of call volume. Over 20% of our call volume nationally is mental health. So we need critical care is great, and they should be utilized to good effect for the patients that require it. But for the vast majority of patients who don't have that, using a resource like that, I think is not the best use, and I think ultimately would end up wasting time and money. What we need are providers who are specifically trained for that wide array of circumstances and situations that can address a lot of different things, but the focus should be on treating patients in their own environment. And if their environment is problematic, finding ways to connect them with resources to improve their environment that will improve their health, that will prevent them from calling 911 and overutilizing scarce resources. So the CT model, good, not. I think the answer for how EMS needs to evolve. I think they have a role to play, certainly, and they should be involved. But when we're talking about what's keeping EMS from flourishing, it's not critical care.
As you mentioned, only 13 states have, EMS provisions for EMS as, a standalone. So do you think EMS response, is it required? Should it be required by state or law? And do you feel it's a privilege or a right?
It's right. I think that we have the expectations that citizens have had the expectations that we gave them. In 1966, when Congress said, we are going to put this group of individuals out there in the world, and they're going to be there to save and help you. And then we spent a decade training the American public to use 911. If you have an emergency, you have a problem, you call 911. You have something that you don't know about, you call 911. As a result, people learned, they do it. They have used 911 to great effect. And then we've kind of crossed that threshold of using it, and now we're into the abusing it. And that's not new to this decade or this century. System abuse began in the 1970s, believe it or not. As a matter of fact, the city of Detroit put out a public service announcement, I think circa 1973, saying save 911 for the real emergencies. But when we're talking about the application of public safety and public health, EMS needs to be in that space. And I think as I said, it needs to be an emergency service. We need to be on parity with police and fire. And those entities are written into statutes at the federal, at the state, at the county, and at the city and local level. Now, I will say and acknowledge that 85% of the fire departments in the United States are volunteer or paid on call. Um, and as a firefighter, I will tell you, it's still difficult to get people to come in and respond to the calls, especially if it's something like a fire alarm. We have a number of volunteer EMS departments across the country. Again, these are individuals who are passionate about what they want to do, but there are fewer and fewer and fewer of them, and they're going out of business. Lack of funding, lack of training, and lack of interest. I think that because we have taught the American public that 911 is the help number, doesn't matter what you don't have to specify. You only get help for certain things. You call 911 when you need help. As a result, if it's a medical emergency, they expect that they will get help. If it's a law enforcement related problem, they expect to get help. If it's a fire, they expect fire department to show up. So we have created this expectation for everybody in the United States, but we haven't funded it. And I think that we have a right as citizens in this country to feel safe, to be secure, to pursue our life, liberty, and happiness. And when there's a problem, that we have the ability to call for help, that it will arrive. And we need to recognize that. And quite frankly, the number of EMS calls that are happening in this country are all they've escalated every single year. The public expects us to be there. It needs to be a permanent and viable entity within the government and within our communities.
So do you feel that for when, at the end of the day, it comes a lot down to billing? And do you feel like the future of ET3 type of implementation would be better served like with regional contracts, or do you feel it's better served with, per supplier?
That's an excellent question. And I'll tell you right now, EMS services across the country could start putting together contracts with health insurance providers right now, but nobody has the time, the amount of money that would be required to have the lawyers review it, or the effort. There are so many health plans out there. There are so many entities that are involved in the process that it becomes onerous. And for a large service, Chicago Fire Department, City of New York EMS, you know, AMR, for instance, they've got the budget, they've got the funding, they've got the lawyers, they could do it. And in several cases, they do have reimbursement contracts with health insurance providers, but that doesn't exist in police or fire. Why does it exist only for us? And I think that when we're talking about contracts and reimbursement models, all of the third-party payers look to CMS. They look to the federal government to take their cues. They don't follow it all the time. As a matter of fact, I know Blue Cross Blue Shield, as a provider, has put together contracts with MIH groups and with EMS services for direct contract reimbursements. And they're not the only ones. But all of them look to the federal government first. What the CMS rules are generally become the rules for every reimbursement entity for all the healthcare provisions. They look at that and they go, okay, well, this is what CMS is doing. Tell you what, we'll make a deal with you. And then they get into the negotiations with the ACOs and other providers to maybe tweak that a little bit. We're gonna charge you a little bit more money for an ER visit, but we'll charge you less than what CMS is charging you for a clinic visit. And that's where you get into the negotiation things. But having a contract with a health insurance provider, it's a contract. It takes time to write, it takes time to negotiate, it takes time to get ratified and then signed off. And it would be much easier to have the federal government, CMS, say, this is the standard, now go forth. And the third-party providers would say, okay, well, we'll take what you have to say and then we'll negotiate a little bit further on our own. But the model structure would already be there, and that would be of great benefit, especially to the small services who don't have the time, effort, energy, opportunity, or funding to try to make a deal with every single entity. That being said, I will also tell you that as a community paramedicine provider, when I was director of the program in Northfield, we billed our patients' insurance companies. So if a patient did not have insurance, the hospital said, okay, we're not going to bill them. But if they have insurance, we're going to bill insurance. The hospital also said, if the insurance company doesn't pay, we're writing it off because we know that the CP program is saving us money. But here's the thing. The third-party payers, Blue Cross Blue Shield included, paid. We charged them $60. They paid it. We had no contract. We had no negotiation. We had no understanding with them. But my suspicion is they looked at the bill and went, that's cheap. Here, pay it off. Let's move on. So we know that CP services and alternate transport opportunities can be reimbursed at a much less expensive rate, and it will cost the insurance companies less, the patient less, and the services less if we incorporate the CP model into provision of the 911 system.
So how has it happened with you, and how do you foresee the community paramedicine kind of integrating with pre-hospital care and quote traditional EMS?
Sure. And that's like I said, that's kind of my vision and my hope for the future. Call comes in. Mrs. Smith has had a fever for several days. She's coughing up quite a bit. EMS crew walks in, whether it's a BLS crew or an ALS crew. They walk in and they go, oh, she's got pneumonia. There's really not a lot of question about it. But she's not very dehydrated. She's not feeling great. We can listen to her lung sounds. We know it's a pneumonia. It's clear, easily discovered. But she doesn't need an ER. Maybe she needs to get in touch with a primary care provider. Maybe she needs some treatment, but an ER is not it. The ET3 model gives the opportunity to say, all right, well, you can go to a clinic. And if she doesn't have transportation, take Mrs. Smith to her local urgent care or a clinic. That's one option. The golden option, though, the integration of CP work and ET3 into the 911 system, is that crew then says, we don't need to go to the hospital. We're going to contact medical control. Doc, this is what we've got. We think this needs a CP call. The physician gets the opportunity to weigh in. Yep, sounds good. Then they dispatch a community paramedic who arrives. Care is transferred, and or the crew can be released from the scene because care is coming. That CP will then provide a higher level of patient assessment because that's part of the training. They will understand the patient's environment. Does the patient have the right finances, the right coping mechanisms, the right structures in and around their house and their social circle to be able to manage things on their own? And if so, or if not, the CP can connect them with those resources. The community paramedic can say, all right, doc, this is my assessment. These are my findings. Here's my thoughts. What do you think? They can have that consultation, again, via telemedicine, and that patient can also be involved in that. So now we've got if the billing model was part of it, that's taken care of. The CP then says, okay, doc, we've got this. This is our plan going forward. The patient needs an antibiotic. And I'm going to do a follow-up in 2 days. That community paramedicine then contacts the pharmacy, sets up or transfers the prescription, or the physician can do it, however that gets set up. And then the patient, if they're mobile, they can go get it. If they're not, it can get delivered. There's lots of different opportunities for how the details get worked out. But that CP hooks the patient up with what they need, leaves, comes back, does follow-up. There are levels of mitigation should something happen, something change, the patient deteriorates. Mechanisms are in place to manage that. And then hopefully the patient does get on the mend, and we've avoided an emergency room. We've avoided an unnecessary transport. The patient remains in an environment that they know and that they feel safe in, and it's a win-win-win.
So, had there been any concerns of, being in Pennsylvania, any litigious issues of someone not going to an emergency room and being evaluated by community paramedicine?
I think that in any model, it's healthy to have some concerns, but that plays into two elements. One of them is training, and the other is that oversight and review. So, as I mentioned, with the inclusion of CPs into the 911 system, I mentioned physician contact twice. So we're not talking about supplanting a good decision-making process. We're talking about enhancing it. And I think that because the level of experience of somebody coming into a CP training program, the training that they get, and then their experience level exiting that program makes that provider that much better. You couple that with consultation, the CP becomes the eyes, ears, and hands of that physician and or even nurse practitioner. And I think that team effort is something that is extremely valuable. And as I said, there's also, if something doesn't happen, if there is a deterioration in patient care, they're not left hanging. It's not, okay, we're leaving now and we're not coming back. It's, I'm leaving now. Here's how to contact somebody if you have a problem, and I will be back tomorrow, the next day, 2 days from now, whatever the case may be. So I don't have a great fear that somebody might slip through the cracks. But to play devil's advocate, that happens in an ER. I mean, the people come in, they get evaluated. Physicians do the best they can with the information they have and the circumstances. What they generally don't know or understand is what the patient environment is like. And people do leave the hospital and go home and have untoward outcomes. So I'm not sure that the human element is ever going to go away, but I feel very strongly that a CP with the right training and a system with the right mechanisms for managing patients would allow a serious alleviation of strain on ER resources and on EMS resources by introducing a CP as that intermediate provider to connect the patient with what they need.
So along those lines, a lot of people in this group are EMS directors. So how can we, or how can us medical directors, how do you go about starting a community paramedicine program at an agency?
That's an excellent question. And quite honestly, it's one of those things that it kind of depends on where you are. But taking Pennsylvania, for instance, operating under the EMS Act is not really going to benefit us. However, operating under the Physician Practices Act, or that actually has some value in what we would be able to do as community paramedics. How do you start a program? First, you need a community health needs assessment. Do you need a program? Is the question. I would grant that most people would argue, yeah, absolutely. Of course, we need a program. We're getting hammered. We need some help. But start with the community needs assessment. Do you have high utilization individuals? I think most systems do. And then where are you going to try to have an intervention? As an example, the CP program that I started in Northfield, Minnesota, came together with a state certification. It took me about 5 years to get a program together. And when we launched, it was actually under a grant from Medtronic. And we worked with a nonprofit group called HealthRise to address patients who had cardiac problems, specifically congestive heart failure and or diabetes. And those were the two groups of people that we went after to try to mitigate their use of services, help improve their long-term health, and address concerns. So to begin a program, you got to figure out what you need. Training is out there and available. University of Pittsburgh, for instance, offers community paramedic training, and I'm working on a model for a certification class that I hope to get off the ground pretty soon. There are a couple of other educational entities that would provide CP training. What I would caution anybody against is just sending someone out to take the International Board of Specialty Certification Community Paramedic exam. That gives you a certification, but you can take it without any training. And if you have half a brain, you probably can pass the test. I'm not saying that it's not a good test, but you do want to have the training component. Training has to involve the understanding of structural drivers of health, of the patient's clinical presentation, of their social presentation, their psychological capabilities, their skill set, their transportation, their income, their documentation, all of those things has to be part of that. And as a CP, you have to understand how those things fit together. And when a patient doesn't have a resource, for instance, health insurance, knowing what the resources in your area are to connect them. So that goes back to the community health needs assessment. From there, funding. Is the EMS service going to pay for it? Is there a grant available? As the medical director, are you in a position to, or are you willing to become that telemedicine physician so that you can reimburse or get reimbursed for clinic visits, but then you're taking on a whole new set of patients? It might also be contracting with a physician group that would provide that kind of service, and then figuring out what those costs are going to be. You do have to have some means or method of transport. I would strongly advise against CPs using personal vehicles, but it does happen from time to time. And then you, of course, are going to need some level of documentation, whether it's access to Epic or one of the other big systems, or if you're going to use an electronic healthcare record attached to the EMS agency's own record system. Some of them using the Nemesis structure will have CP add-ons, things like that. And then there has to be a level of data analysis. Is what you're doing having an impact? Is it making a difference? So those are kind of the steps involved in starting a program. Certainly, if anybody has questions or wants to talk more about it, I would be more than happy to discuss this. As you might have kind of figured out, I love talking about community paramedicine, have for some time, ask anybody. But the ability for a service in this state to start a CP program is not out of the realm of possibilities, but it's going to take some intentional steps to do so. In other states, it's already in statute. It's there. I know in Minnesota they put together a toolkit. California's got a number of programs. I think one of the first programs in the U.S. was in New Mexico or Texas, and they've been around a while. I know that many states in the Midwest have got programs, Florida, up and down the coast. So there are a lot of programs out there. There are a lot of national organizations that would be happy to share information or to get people connected with folks who would be good as consultants or resource providers, things like that. So there's a lot out there. It's just a question of saying we have a need and we want to try to figure out how to address it. Beyond that, what you do, how you use the CP program is entirely up to you. As a community paramedic and as a service director, we did a lot of stuff. And when my medical director said, "Hey, I got a call from Dr. So-and-so, can you guys do heel sticks?" Well, no, we don't know how to do that, but what do you think, Doc? And she would say, "I think we should do that." So we went through and we got the training. We did the practice. We got the verification and sign off. And then we went out and did them. So you can do a lot.
Thank you. That gives a lot of food for thought, especially if, I think, like you said, if you do a needs assessment, I think most places do need it. And I think it comes down to then, the additional training. So do you feel that trying to get, pre-hospital providers, where do you feel the state of pre-hospital providers are in the realm of EMT, paramedicine? Is there a paucity of them? Do you feel that that's a driver is based on economics?
Oh boy, that's kind of a loaded question, but I'm very glad you asked that. So to answer that directly, yeah, we're in trouble. Paucity is a good word. I will tell you that in Pennsylvania, in the largest county in Western Pennsylvania, or most populated, Allegheny County, when I took the position of EMS chief, I did a little research. In the year prior to my taking the job, the decline was 4%. We lost 4% of all providers in the county. Last year, it was 10%. Those are experienced, capable, competent providers who don't want to do the job anymore. And those, I will tell you, those are the very individuals that we need to be thinking about for community paramedicine, because they've got the experience, they've got the time, they've got the face-to-face patient interaction down, but they want to do more. Or more specifically, what they don't want to do is go up and down stairs wrecking their backs because they can't accomplish that anymore. Those are the candidates that are perfect to move into community paramedicine. And some people, it's when you start out 911, adrenaline, yeah, lights and sirens, go save lives. I was that guy. I've been there. Sure. But there comes a point where you go, I've been doing this a lot and I'm doing the same thing again and again and again, and I really like to do more. And then when I learned about community paramedicine, and when I learned about the capabilities and the skill set, I was like, this is really cool. I mean, suturing, I got to be honest with you, it's kind of fun. I'm not a guy who likes to sew a lot, at least not clothing, but stitching up an eyebrow, that's kind of cool. A lot of the things that you can learn or improve as a healthcare provider are out there, and giving that group of folks who are looking to do something else. They don't want to do the street anymore. This is a venue, a career ladder change for them. So we do have a lot less EMS providers nationwide, not just in Pennsylvania, not just in Allegheny County or Washington County, across the country. We're losing them. Partly because the job itself has continued to be what are you going to do until you get a real job attitude. It doesn't pay a lot. I've made a career out of this. I'm not a rich guy. But when I moved into community paramedicine, I was like, wow, this is like starting all over again. This is cool. I'm excited about the job. I'm excited about coming to work. I know that I'm doing good for people, and I'm making a lot of improvements. There's a greater responsibility. There's a greater expectation. Yes. But aren't we all trying to do the best that we can and learn and be the best and most capable? So yeah, I really think that we've lost a lot of people, but we've got room to bring them back.
Great. Do you talk to anyone over the pond? Are there programs like this over in the UK that you're aware of?
Oh yeah, the community paramedicine programs actually are popping up around the world. I know that Australia had a really, really robust system, but those guys, those guys are doing some pretty wild stuff. Firstly, because the some of the areas in Australia, and not having been there, I am not an expert by any means, but my understanding is you're talking about people who are out in the middle of 100,000 square miles, and there's no physician or anybody else. So they're sending out CPs there to do everything, provide primary care, to get involved in whatever healthcare issues happen to be going on. And they do a lot. They do a lot of really good work. In Minnesota, Dr. Mike Wilcox, who was the physician primarily responsible for bringing community paramedicine to the state, his goal originally was for rural patients, not for urban circumstances. And what ended up happening was the CPs at Hennepin County Medical Center started going out and seeing those high utilization patients where they were. Well, when where they are is underneath the bridge and that's where they live, that's where the CP went. And we were finding that in all of the circumstances, we were having positive impact on the patients. Not necessarily solving everything, but doing good for them, improving the circumstances for them where they were no longer taking up all of the time and resources. If somebody's sick, get them in the hospital. That's where they belong. But if we can fix it without having to do that, so much the better. And if we can fix it without having to do that at a pay rate that is sustainable for us and not too bulking for the insurance companies, that again is a win-win. So we have we have a lot of good opportunity.
Thank you. As we start closing down, I mean, this was really, really informative. What are your kind of main key take-home points you would want to drive home?
Talk to your legislators. There are three things that EMS needs. We have to have education. We have to have legislation. We need to achieve that emergency service status, and we have to have reimbursement. Whether the government says, okay, EMS is now something that everyone is going to get, or whether we're going to continue in the healthcare reimbursement model with the understanding that we get paid no matter what when we get called. Police departments get paid no matter what when they get called because the taxes say you're gonna get your pay. Cops don't work on a per case solving kind of model. The fire department gets paid no matter what. They go out on an alarm, it's covered. They go out on a fire, it's covered. Where we run into problems is when we say those are important, but EMS, yeah, it's not that important. It's not a big deal until you're needed. And as I'm sure many people in the audience already know, EMS is also that catch-all. So when somebody calls and the cops get there and go, this really isn't a law enforcement thing. And the fire department shows up and they go, yeah, it's not a fire thing. We're not really sure what it is. Let's give it to EMS. And now we're stuck with, okay, well, I guess we'll figure it out. Those are the circumstances where, okay, we're going to figure it out. We're going to spend time. We're going to put some effort into this. We need to get paid for it. I've had more calls than I can even think of where I get to a scene or a situation and the patient just needs help, but there's nobody else that's willing to help them. I had a patient who was 5 blocks away from home. Cops were not willing to give him a ride. Nobody else was there. The guy had an injured foot, couldn't really walk. Put him in the truck, take him to his house, tell the dispatcher, I don't know what happened, he's gone. We did good for him, but we don't have the structure, the procedure, or the model to do good for people and get paid for it. So we end up doing our best, and the services can't sustain themselves. We end up doing our best, and the people get burned out. We do our best. We need help.
Thank you. So please join me in thanking Christopher Maddock for taking his time, sharing his expertise with us. Um, I really, really appreciate it. If there's any follow-up questions people have, feel free to reach out to me and I'll try to forward them to you if I can. But I want to thank everyone for their time. I also, this is the time to kind of plug, if you look in the chat, our next webinar, which we'll be talking about equestrian emergencies in sports medicine. So it's a little bit different, obviously, but please go to our website and check that out to learn more. But thank you everyone for joining us, and we look forward to seeing you again soon. That's all I have, and I want once again thank you, Christopher, for your time and expertise. And everyone have a great night.
Thanks very much for having me. I really appreciate it, and I can see I've got a couple of my students who are in the audience. So hello to them. Thanks for joining us. And please, if you take away nothing else, contact your legislators. Tell them we need help. Get them involved.
Thank you. This will end tonight's program. Everyone have a safe night. Happy holidays.